training and also the schooling from Varanasi. So the culture is very familiar. And I did my faculty, was faculty in SCPJ for 15 years as a professor of GI surgery before I shifted to the Vedanta. Right. Thank you for the nice words. Before not spending too much time on introductions. Achalasia cardia is a rare disease, but the disease is quite problematic because the patient comes in with the dysphagia and doesn't eat much. He starts vomiting and the registration of the food material, and he starts losing weight. And sometimes, the patient is not actually knowing exactly what is happening, and few patients develop lung abscesses because of aspirations. So it is a quite old disease. It is as old as 17th century. It was described by Willis as a food blockage in esophagus, and he was treated with the whalebone sponge. It was in 1927 and was coined the term achalasia. And then Esley Cooper in the same year has started business of those lesions. But if you go again back to the history, there is a surgical treatment has been offered, and Zaffe has in 1897 did the excision of longitudinal strip of muscle from the lower esophagus. The Russell has introduced the inflammable silk and rubber bag dilatation. Then the cardiomatomy has been suggested by Gottson. Then Heller did a first classical describe a myotomy what we do today. And then Zeiser has popularized the anterior cardiomatomy because the Hellers had done a myotomy in the two places, interior and posterior as well. It was technically difficult, has a more complication rate, but then the anterior cardiomatomy what we do now is the most common one. So what is achalasia cardia? Achalasia cardia is an esophageal motor disorder characterized by the aperistalsis of the esophageal body and the lack of relaxation of the lower sphincter in response to swallows. Pathophysiologically, the achalasia is caused by the loss of involuntary ganglion cells in matrix plexus. So there are three types what we encounter in most of the practice: the primary achalasia, secondary achalasia, and pseudoachalasia cardia. I'll retreat by one. So what is the pathogenesis of achalasia cardia? See, usually we do not know exact pathology of the achalasia cardia, but several hypotheses have been introduced. There may be some viral infections like measles, varicella zoster, herpes virus. There may be some neuroendocrine degenerative disorders. There might be some autoimmune disorders. There will be anti-myelinic neural antibody has been shown in few patients. A few patients with the HLA DQA1 with focus 101, 502, or 061 has been also been implicated. And so there also been insight that the person who carries these HLA might have a genetic susceptibility because they may carry on this disease to their kids. But these are all hypothetical. It's not been well proven by most of the studies. How it happens? The matrix plexus inflammation and neurodegenerative disorder lead to the loss of inhibitory neurons, and that lead to the decreased inhibitory neurotransmitters. And then, but the chronologic transmission is remain intact, so there is an imbalance, and that led to the achalasia cardia. So this is the high impedance manometry. KK must be knowing this. This is high pressure zones in normal esophagus. You can see the black dots. And when the loss of inhibitory neuron has stopped happening, the dots start increasing up, and then the inhibitory neurons goes down, and this led to the achalasia cardia classic. This is the progression of the achalasia cardia. How it happens. So this is believed to be multifactorial, with autonomic mechanism triggered by the infection in a genetically predisposed individual, leading to the degeneration of inhibitory ganglion in the wall of the esophagus. That's the hypothesis or the definition what we carry until today. So how do we diagnose achalasia cardia? The most common is the barium esophagogram, upper GI endoscopy, and manometry. See, upper GI series, if we find the patient who has achalasia cardia has esophageal dilatation. In the advanced cases, they may present as a bird's beak appearance, which is a classical or pathognomic of the achalasia cardia. Absence of gastric air bubble on frontal air. There might be a sigmoid esophagus with food residue where the Akiyama axis has been disturbed, and this is pretty advanced achalasia cardia. And then this dilated esophagus with filling defect, and if there is there, it's called malignancy, and probably it is not a pseudoachalasia cardia. It probably may not be pseudoachalasia cardia because the difference in the developing malignancy in achalasia cardia and the patient has achalasia cardia because of malignancy is two different things. So one has to make sure that the achalasia cardia might harbor a malignancy because of achalasia cardia. This is a classical bird-beak appearance shown in MBBS and MS exams. And this is the megaesophagus. So you can see the axis deviation with a lot of food material. And this is a torquing of the esophagus as well. So operative endoscopy is, in fact, not much has been added to the diagnosis except ruling out the few findings like that is the food residue, ulceration, slough. There may be mass in present. There might be bleeding in the esophagus. And to rule out achalasia, pseudoachalasia cardia, one has to do an endosonography or CT scan. As I said earlier, that the per se for diagnosis, the operative endoscopy doesn't add too much. So manometry is gold standard. It has 5 classical findings, 2 of the lower esophageal sphincter and 3 the body of esophagus. So these are the 5 criteria have been used in manometry. The first 2 major criteria is if LES hypertensive, that is more than 35 mm of blood pressure is present. If LES fails to relax with deglutition. And the 3 other criteria is pressurization of esophageal body, the spontaneous mirrored contraction with no evidence of progressive peristalsis, and the low amplitude waveform due to the weak muscular tone. These are the manometry. I'm not going to detail into it, but you can see the relaxation and loss of relaxation happens when the wet swallow and dry swallows happens. So manometry, in all the common manometry is high resolution or high impedance manometry with pressure tomography. And based on this, 3 types has been reorganized, type 1, 2, and 3. Type 1 is called classical achalasia cardia. Type 2 is compressive achalasia cardia, and type 3 is spastic achalasia cardia. Why more important? Because these 3 types of achalasia cardia actually prognosticate the patient and the treatment you offer to them. And they have shown the response to the different treatment. I'll go to one by one. So classical is type 1 achalasia cardia. What happens here? There is an impaired LES relaxation. There is no significant pressurization within the esophageal body. So actually it is complete most of the time with paralyzed esophagus. And that's why the response rate, if whatever surgery you do, whatever the manometry use, whatever the balloon dilatation, or even POM is done, the overall, the response rate is up to 60%. So 40% patient will not respond to whatever treatment we offer to them. If there is a compressive achalasia cardia called type 2 achalasia cardia, they are the best patient for the treatment because in this patient, the rapid pan-esophageal pressurization due to the large water swallow and LES relaxes when the column pressure exceeds LES pressure. And this is a very classic patient which comes to you and OPD and say that he is to take a lot of water to get the food down into the stomach. And these are the patients who respond very well to the treatment, whether enzymatic dilatation is done or cardiomyotomy is being done. And the overall, the response rate is up to 100%. The type 2 achalasia cardia is the achalasia cardia actually which respond best to the treatment. And the worst is the type 3 achalasia cardia, also called spastic achalasia cardia, where the rapidly propagated pressurization due to the abnormal movement and auditory stage contraction. It is sometimes like nutcracker esophagus. It's very similar to it, not exactly nutcracker, but very similar to it. And whatever we do, whatever surgery, medicine you do, response rate overall is just 30%. So that's why most of the patients we kept on the prolonged medication, like calcium channel blockers. So this is a small algorithm is being there. If the patient has the dysphagia, right? And if there is and patient has suspecting have achalasia cardia, then a differential diagnosis can be made. And it should be, there has to be, it should be the other cause has to be excluded like irritation or burn. If it is present within the barium swallow, it comes achalasia cardia, then go for manometry and barium swallow to diagnose. And if it is not, again go for endoscopy and then doubt achalasia cardia or primary achalasia cardia. So treatment basically is very straightforward. Drug is hardly much of value in initial phases. Dilatation is the most of the time it is being done and offered on most of the gastroenterologists. Surgery is the gold standard where the most of the report or most of the treatment options being compared with the surgery. As recently we have started using a per oral endoscopic myotomy, now it is being very frequently be done in most of the centers like third space endoscopy. And stent is done in a case where condition doesn't permit or patient has a malignancy into it and not eligible for any major surgery or major intervention. So drugs when described in treatment is achalasia cardia, nitrates, calcium channel blockers, sildenafil, and Botox. If a Botox response pretty good, but the recurrence is as a rule within a year it recurs. Dilatation is they have been described like self-glutinous metal dilators. Initially, it was a Negus or Plummer dilator has been used as a hydrostatic dilator, but now pneumatic dilator is the norm, and they are being frequently been done by gastroenterologist friends. If you see the one report published in 2006, what actually have shown that the up to the 40% of the patient may remain symptom-free up to 5 years by single dilatation. But if you do the multiple dilatation up to 6 years, they can be symptom-free by 44 years. And there are comparative studies published. So, but the complication, it also has some complications. Up to less than 1% patient may have hemorrhage, but up to 10% they may develop obstruction. If you do the repeat dilatation, the multiple, or if you do the high pressure or high time dilatation. So risk factor is a larger balloon, talking of esophagus, diverticula, high resting tone of LES, male populations, and the multiple dilatations. Now, the surgery is the gold standard. As a surgeon, definitely I'm going to propagate surgery, but surgery is the gold standard, and most of the treatment or modality being compared with surgery. It's open surgery and laparoscopic, because open is not again a safety net in this procedure. The laparoscopic is the norm in a cardiomyotomy. I just go through this very small video too after this. What we perform as a standard is anterior cardiomyotomy. It's approximately 3 to 4 centimeters of the dilated esophagus and up to 3 centimeters of the cardia. Fundoplication may or may not be added. It could be door or tupé as preference goes, because most fundoplication serve the purpose. A leak check has to be done, and if there is a small leak is present in the mucosa, exposed mucosa, one has to repair with the fine cord sutures, or maybe you can fashion a door wrap which work as a thal patch to the perforated esophagus. RT is being placed for 24 hours to just prevent the retching, and orally patient can be allowed on the next day of surgery. So the success rate of the most of the study shown more than 90% at the end of 10 years, and it has been for us, it is the first line therapy. The complications very few and far, and most of the systemic reviews and meta-analysis favor surgery over the dilatations. There is a lot of debate about the length of myotomy, fundoplication, first or second line treatment. I'll go through it later. There's a small video I want to play. Somebody know how to play the video, please? Yeah. As a small video, I just 5 minutes video. A patient. Can you into the light, please? It's really dark. Okay, fine. A patient basically in the back, in supine position with the leg spread apart, which is called modified lateral procedure. So the position is the modified Lloyd-Davis position. Sorry for some problem in this. It's running smoothly. It's in my laparoscopic method. It's a standard 5-port what we do. This is a suprabrachial port for the camera, 2 working port in the subclavicular line, 1 in the epicastrum for the liver retraction, and another port down here to relate to the fundus of the esophagus. This is a classical 5-port surgery is done in the Achalasia cardia. The same port also been used for the laparoscopic fundoplication as well. In the surgery in the stomach, like in the radical gastrectomy, also the same port is used with the difference in the working ports. Sorry, the glitch happens. When it happens, we're not expecting it. Right, so the 5-port is described. The 5-port we use most of the cases surgery. And this is surgery, this is hiatus, this is supramental. So once you go in, You can see the past flexi-lab method, but it is cutting the lesser momentum, creating a window. This is the left lobe of the liver. This is the stomach, and we're cutting the. Okay, so we're just cutting the. Hmm? Beautiful video. Open the video. Open the video. All right. We're just directly playing the video. It's not working on the link from the PowerPoint. Okay. It's about 8-minute video. We lost 3-4 minutes in this thing. So I think we should give some time, 2-3 minutes extra. Thank you. So we're just getting the lesser momentum and going to the lesser side. And this is the left lobe of the liver. This is the stomach. And when it is being cut, we are reaching up to the superior part of the area. And this is peritoneum over the superior. And once it is cut, and then you can just see behind is the phenoesophageal membrane, the divided that membrane, because that basically cleans the esophagus and separates the esophagus from the hiatus area. And this is a window is being made. We're entering into the left side of the esophagus. These are peritoneal attachment being cut. Quality is not good somehow, but on the laptop is pretty good. And you can see the phenoesophageal membrane basically, and the esophagus is being pushed down from my left hand. And once it is cut, then you're going to enter the left crust and killing the bare area also too. So when after this maneuver, the esophagus is completely freed from the hiatal area. Right? And this is the window we have made on the side of the esophagus. You see the window? Now this is a retractable window and a space being made between the esophagus and the crust area. So you can see that. Right. And after that, we are just we are dissecting around the esophagus because you see the esophagus is visible, which has an Achalasia part. So when I have to mobilize esophagus all around, because once myotomy is being done, one should have at least 4 centimeters above the G junction to make sure that you get a good pattern. So this is the data so that you can actually see. And then it's dissected all around so that the esophagus is totally free and to fashion a good pattern. And it's done a blunt dissection. This patient has not undergo dilatation because patient who has undergo dilatation usually have some element of periesophagitis. And those patients, the dissection is not as smooth as this patient because this patient is a renal patient, came directly for the pyotomy. And this is the pad of fat and the cardiac pad of fat is being removed because at this area where the G junction you can see an anteriorly should be cleared from the fat area. Sometimes the interior vagus passes from left to right this position, and it can be cut. So one has to make sure that if you see the vagus, one has to preserve that. And this is the short gastric being removed from the spleen. This is junction with the sphenogastric ligament, and here the attachment of the fundus to the left crust being dissected out, and the whole fundus is being mobilized. And you can see the left crust. This is very important maneuver because unless you see the left crust like this, you cannot function the good frontal ligation. So if you're going for a two-way, because I prefer two-way frontal ligation over the dog in this patient, that's why I'm clearing this area. If you're doing a dog, this dissection is not required. So this is shown maneuver because if you want to fashion a floppy frontal ligation, floppy is a very loose frontal ligation. So when you have to check this out, get this the fundus system on the other side, and do a shoe shine maneuver. This is a frontal ligation. This is a frontal ligation. So again, this is called shoe shine maneuver. Once it is there, That means you have adequate localization. After that, the renal surgery starts called myectomy. And here the esophagus is being pulled down a little bit so the axis becomes straight. And then by the blood dissection and the energy source, a myectomy being performed. I can see that they start the teasing out just above the G junction and the teasing out. You can see the mucosa is bulging out, right? This is more. I shouldn't bring that. Now I can see this here. Now this is the muscle, longitudinal and the transfer, the longitudinal muscle and circular muscles. This is longitudinal muscle being teased out. You can see the mucosa popping out. This is the mucosa which pops out when you are in correct plane. And then you make a plane with the manual forceps. Make a further plane, separate the submucosa down there. And then you again tease the muscle out or cut it and use a simply tease out because teasing causes a lot of bleeding. So now prefer a harmonic scalpel to cut the muscle. And further plane is created between the muscle layer and the submucosa. Here the point of concern is it bleeds sometimes because if you tease the muscle, bleeding happens. Because there is very close proximity to the submucosa, someone should not use any cautery or electric cautery. Use only a simple gauge piece and press it out. So the pressure, by pressure, bleeding stops. Now the most crucial part is this part because here the submucosa is very densely, mucosa is very densely adhered with the muscle layer, the crisscross fibers, called the color of Helvetius. And here the maximum chance of the perforation to the mucosa occurs. Here I have to be very careful and do the teasing is very careful. And at least 3 centimeter has to be cleared down from G junction. So this is my open forceps, which actually 3 centimeter. So you can actually measure it out here. Once it is done, then you fashion a fundoplication. And before that, you can go for the leak test. You put a small rice tube. You can actually see the rice tube passing through this. You see the rice tube passing through. Then you see the rice tube passing through the stomach of the fundus. Then you further pull it up to the where the part of the esophagus is exposed, and then you put some normal saline or maybe some resident glue, push it out again, check it out if it is present or not. If it is present, you have to repair it. And now the tube fundoplication is being fashioned, and then the edges is sutured to these wrap. I'll just stop it because it's not much. Presentation. I'm sorry, there's a glitch, so can't help much. So the last line we just switch off at that time. The length of myotomy, the debate is length of myotomy, fundoplication, first or second line treatment, how it has to be done. So the several studies has shown to favor or not to favor the addition of fundoplication with heterosclerotic myotomy. And one double-blind RCT has been published, which shows a 9-fold decrease in GRD if there is no increase in dysphagia of addition of fundoplication. So fundoplication now being preferred, but again, the question still remains whether fundoplication is still required or not required. Only few surgeons now do not add fundoplication. But this study in 2004 is more than 2 decades in past. But the confusion still continue. But Another concession has been done in 2011 when Kagoshima concession has been done, and what actually end of the 3-day symposia, what they found that despite the variation as to the length of and the addition of anti-reflux procedure, good overall long-term results suggest that these operative variations are not critical. So that means one can escape fundoplication if it is patient thing or Dr. Singh doesn't require, or manometry does not shows that I think this may not be required. We should not add fundoplication research. So a lot of controversies happened in same year when one of the NEGM article published that show the liberty dilation versus laparoscopic keratotomy for idiopathic Achalasia cardia. There's no significant difference between these two, but the COVID is the follow-up is just 5 years. And after that, the follow-up study published again in 2018, which shows that the keratotomy has far better result as compared to the dilation. Now, I'm not going to much detail. Dr. Gastroenterologist is already present. I just go through a few lines. The technique is basically same what we do, but they're done from inside. So the endoscopy, cut a mucosa, create a space between the mucosa and the muscles, and then you cut the muscle up on the G junction. And then after that, cutting the G junction, the muscles all over, just come back and put a clip over the mucosa, and poem is done. And basically, this indicated advanced disease or severe fibrosis. This is the way it is being done. I'm not going to go detail. Again, it is sophisticated and demanding technique, even for the experienced endoscopists. There is some serious complication happens, like metastanitis, and if this happens, the patient's life is at stake. Regional surgery is very difficult and involve very extensive procedures such as esophageectomy may be required because the plane between the submucosa and mucous muscular layer will be inflamed and scarred after endoluminal approach. So if to conclude that despite the ongoing debate and the report of the first randomized control trial, the minimally invasive surgical treatment seems to yield better result than a dilatation with the currently available evidence despite being less cost-effective and resulting in more reflux symptoms. POEM is promising technique and associated with the good short-term results without serious complications, but long-term results yet to be available. But now it is being published for years because more than 8 years has been since POEM being started, and actually they're showing very good results. And future, we say that despite these advancements, the actual cause of achalasia had not yet been identified, and this knowledge may improve treatment success in the future if we know the cause of achalasia. Thank you very much.